I'm going to talk about a little about the whole evolution of the doctor-patient relationship. I'm a cancer specialist. I've been working for the best part, more than 2 decades actually, looking after patients who unfortunately have a diagnosis of cancer as part of their affliction, which causes lots of stress, of course, death, morbidity, mortality. My job over the course of 20 years is realizing what's my role. Am I purely a technician, holding a knife, scalpel, offering operations when it's appropriate, or is it more than that? What about the communication that takes place from the whole subject of health? So let's take you into a little story. Imagine coming to my world for a moment or two. On Tuesday morning, just gone, I was in my clinic at the Royal London Hospital, a stone's throw away from this establishment. I sit in my clinic with my nurse specialist and my team, look through the patients I'm going to see that morning, most of which have had a new diagnosis confirmed or about to be confirmed on that appointment. We make a few decisions, roughly what we're going to say to them, how we're going to manage their expectation. I then walk out of the room, into the corridor, and I walk out into the reception area where there's just a melee of people waiting for various appointments in the hospital. I then call a name loudly, the next patient to be seen. That's my first interaction with that patient who's about to get a diagnosis of cancer. They get up and look into my eyes. My first interaction is the visual cue. I try to assess originally, straight away, what's the expectation? What am I dealing with? How am I going to overcome some of their fears and horrors that might come through the diagnosis to be made that morning? So, next thing I do, they come, I greet them. I shake their hand. The first touch of human behavior in medicine. I look in their eyes and say, I'm Shafi Ahmed, pleased to meet you. Come with me and take a seat. So that's the first connection I make with a patient that's got a new diagnosis. And then we bring them into the room. We sit them down. And it's always difficult to know how to approach that communication tool. How do we connect with that person immediately? How do we reassure them they're in good hands? How do we assure them that they've got expertise around them to look after them in this difficult time? So normally I ask them, how are you? Tell me more about yourself. And they'll start talking about themselves, hopefully, to start breaking the ice. I then come down to the problem. I ask them, do you know why you're seeing me today? To get insight, to find out what they understand about their problems. And most of them have an inkling, of course, before coming, because they've had CT scans, MRI scans, endoscopies. People aren't stupid, of course. They know that we're investigating a problem. Then, of course, we sit down and we break bad news. Sometimes the bad news can be good. It can be ways I can cure people with a knife, with an operation. Alternatively, it might be chemotherapy, radiotherapy. Sometimes, of course, it's palliation only. We have to break bad news that we can't really offer much treatment to their condition. Often, they may be upset. They may break down in front of us. They may start crying. When they do that, of course, the first instinct that we have is that we go for the tissue box. We offer them a tissue. It's a sign of insecurity on my part almost, saying that I can't really help you, but I can get a tissue for you at least. It's automatic for us. We then often hold their hands, support them or touch them on their shoulders. It's going to be okay. We'll do our best that we can for you. So in that environment, we've met the patient, we've met them through the eyes, we've touched them, they've heard our voice. We try to have soft tones in our voice. We then bring them in and break bad news and again, hold them, and hopefully we can help them in that regard. My question to you now, in this talk I'm going to give around the evolving relationship, is how has it evolved over thousands of years? And now with technology interface, is it changing? And do we need to change the way we behave? Do patients need to change their expectations of what's going to be afforded at a consultation? You see, we have a problem globally. We don't have enough doctors. We need more surgeons around the world. 2 million today we need today just to make sure healthcare is more equitable. Healthcare resources aren't sufficient. All healthcare systems in the world are struggling with resources. How do we make it more efficient? How do we see many more patients? Can we actually offer them the time that we've been given in the past to break bad news, to teach, to sort of treat them, talk about their prognosis? Are we in a rush? Suddenly our lives are a one-click Amazon, one-click Just Eat. Are we becoming a one-click doctors? Are we suddenly changing the paradigm of healthcare? When I qualified, we all sat and took the Hippocratic Oath, who was written 3,000 to 5,000 years ago, probably, as the first doctors. This was about our role and our pledge to our patients. This is the Declaration of Geneva, which has superseded the Hippocratic Oath. This is what I said when I qualified back in '93. We stood up and we said these words. It still remains true today, but however, it doesn't say you can't use technology. It just says these are the parameters of your relationship with your patient, which is obviously sacrosanct. So my question now is, can we challenge some of this? If you look at history, already predicting our behavior, we've now got a plethora of telemedicine devices. You can now pick up a smartphone and communicate by mobile phone, by WhatsApp. You can stream live on Facebook and social media. Suddenly, connections are slightly different. And the human interaction will change. It has to evolve because of the people that we are and how technology is going to interface in our clinical practice.
How are you, sir? We're doing the recording, as you know, and Mr. Ahmed's on the other line. So he will tell me if there's anything he wants me to do on your side. Okay? There's about a 15-second delay from what I talk to from what he tells me, so bear with us if that's okay. I'm just going to show Mr. Ahmed the consent form of the actual operation, so just bear with us just a minute. And essentially, I don't know if you can see this, but his hemoglobin from yesterday was 12.1, his white count is 10.5, his renal function is normal, and his creatinine is 81. His CRP is a little bit up, it's 138 from 103. That's because of that pelvic collection. Is he booked for theatre? Okay. He wishes you all the best and he'll see you tomorrow. Okay. See you tomorrow. Yes, you are. See you later.
So, this is my trainee wearing a Google Glass, wearable technology, streaming through his points of view. I'm on a mobile phone or a computer somewhere else, giving instructions by text message, which comes up on the glass, saying, this is okay, go ahead. There's a communication there, but I'm remote. Is that enough for the patient to be thinking of the consultant seeing him and managing his condition? Or say I'm on holiday, it'd be like me to be there, for example. Would he prefer that to somebody else that's not seen him for forever, who's not his patient, for example? So we've got to think about how we change the way we look after people.
Come in. Ms. Shafi.
Oh, hello.
Come in.
Oh, hello. Thanks.
How are you?
I'm okay, thanks. How are you?
I'm okay. How have you been before you left?
Yeah, there's been some progress. Getting stronger, putting on weight.
Okay.
Yeah.
So can I just ask you, so tell me what's been happening the last few months?
Well, I've gone back to work, part-time.
So Pamela, how would you feel about me seeing you through a telepresence system? For example, if I'm not here in the country or I'm elsewhere, I could just, and you come to my clinic, how would you feel?
I think it's very helpful to see you because I want to see my consultant when I'm here. I think it's great to see you and hear your voice and to talk to someone who knows my case, actually. There's some continuity in these 2 years of seeing you, so I think that's a perfect solution.
Do you think there's anything missing with the human touch? Because obviously you can see somebody, they can move around, or you can hear their voice. What do you think about the human touch?
Yeah, I'd prefer to obviously give you a hug when I see you because that's really important to me, but I think
Is
the
it
voice
necessary?
is also important. It's not necessary, but it's nice.
Could you cope without it? I mean, the whole point is in human existence, we think that's important because we created that situation that we believe is necessary. What do you think?
I think it's important to have eye contact as well, not just human touch as well. So just to be able to see you, to see your smile, and to see you is also important.
So the patients obviously have an expectation, an understanding of who we are and what role that we have in that situation. What about our own colleagues? So I obviously go to operating theatre, I operate every week. What about how they communicate with me if I wasn't there?
Hi Simon, thank you Simon. This is going to theatre 2.
Yeah.
Hello everybody.
Hello.
How are we doing?
I'm good.
Are we ready? Are we sent?
Yeah, we're set.
Are we sent?
Here, go for it.
Let's try team bridge. Come on.
Yeah.
Introductions. Simon Surgeon, his name.
Oh, the anesthetist here. The anesthetist is in the... The anesthetist is here.
Oh, yeah.
They're looking for the anaesthetist who's sitting with me on the iPad. So that's why they're a bit confused because they have to start the operation without the anaesthetist. That was interesting. And just I did that. I did the MDT, I did my ward rounds, and interesting, within about 2 to 3 minutes, it suddenly becomes normalized. Suddenly, this machine contraption with your face on it, which moves around a bit, is normality. People turn around, ask you questions, they discuss things with you as if you're just there. It's incredible that we just accept these things changing very rapidly. We need to ask the question and to challenge the dogma and tradition that's associated with healthcare and technology. Of course, there's all this. There's now artificial intelligence. Within the next 2 to 5 years, the first point of contact will not be a human being. It's going to be AI in the background, chatbots, other mechanisms of communicating with people, whether it's non-human, whether it's created by avatars. So now, in parts of the UK and parts of the globe, you can ask questions to a chatbot. There's no human interface, there's no touch, there's no eyesight. It's just asking question after question, an algorithm-based, gives you a diagnosis, and now it will say to you, go and pick up a prescription from the chemist, it's already done, without ever seeing a doctor. We've got to get used to this, because this is the way we maximize efficiency in healthcare around the world, because that chatbot could treat millions of people in one go, whereas individually it's much tougher. So we've got a global problem with lack of resources, lack of doctors, so AI is going to change the way you work. So remember, the next 2 to 5 years, your first point of contact will not be anything like me. It will just be an AI system working in the background. We can go further. What about if the AI system becomes more realistic? This is me with 104 cameras creating what's called photogrammetry, creating my avatar, a volumetric part of me. What if we add facial expression to that avatar? That's my avatar. And add human contact and facial expression, smile, the eyes will change. Add voice with interface in AI. So you ask it a question, it talks like me. It acts like me, it has knowledge, but much more knowledge because I'm only confined to 22 years of clinical practice. This thing will have knowledge across the entire Google spectrum, much better than me. So suddenly, and that could teach or treat millions of people, right? So you're expanding healthcare, you're making it more efficient and expanding and scaling up. And perhaps that's where we need to be in the future. Next bit I'm going to do is I'm going to test some tech. So we've had a few issues today. I'm going to show you something that hasn't been shown before, first time, and I thought I'd showcase it in this TEDx. It's about how we communicate in the virtual space. So give me 1 second and I'll set it up, and let's see if it all works. Lovely. So let's play a video for you, which will demonstrate what I'm trying to do now. I'll try to figure it out.
As well as this backbone of, for all 3 of us are in different cities right now. Harris and I are in America, and Shafi, you're there in London, I believe. Yeah. But we're all here together face to face in an OR, and we're able to share that 3D content, whether it might be an MRI scan or existing anatomical models, and we might be three doctors coming together, able to put our heads together face to face, no matter where we are in the world, communicate and collaborate and really problem solve around that particular patient and their needs.
Absolutely. So that's the kind of thing we're doing. In fact, I can see both Ian and Harrison here with me, right next to me, and they're talking to my ear at the moment, and we're actually having a conversation in the background, just similar to this. So you can share assets, you can probably go ahead and bring scans in, and ultimately, we can be in a position in the future where you may end up doing virtual reality operations, start feeling in touch with haptic gloves and things in this whole exciting space around augmented reality, virtual reality, and mixed reality. So my message really at the end of all this is the fact that, I can take this off now, that we're going to change. And I think we need to adopt different ways of managing our patients and expectations. We have to evolve as human beings, and I think part of it's going to be around psychosocial behavior. What's the expectations we have? And we've got to challenge the way we've done things for many years, because we have a global problem of shortage of doctors and nurses, and we also have a shortage of resources, and we need to improve the efficiency of our health service. And perhaps these are the kind of technologies that will help us empower ourselves, but also our patients. Also, a quick thank you to Pamela, who's on the video that you saw, who allowed me to video this. All my patients who really support innovation, who don't mind being shown in the world, the stuff that I do with surgery and training on a global level, but also sharing their stories with people like yourselves. And Pamela is actually in the audience today watching this, because I want to share that with her, that story. Thank you very much.